What's going on, everybody? What is going on? It's your boy, Julien Stoutt, licensed personal trainer, licensed PE teacher, world record powerlifter, here to take the fear out of fitness. We're about to take off and class is in session. Puerto Rico, ho, Puerto Rico, ho, Puerto Rico, ho, Puerto Rico, ho. Yo, shout out to all my Puerto Rican brothers, sisters, and cousins, literal. So, all the people that I grew up with in New York, what's going on, y'all? How y'all doing? You know who this is. You know what I do. We about to get down. You see the title in the thumbnails. It is Injury. We are discussing injury and rehabilitation. Actually, this is my wheelhouse. This is what I'm actually good at. This is when I say actually good at, like I am like next level with it. All right. And I'm not saying that just because it's me saying it. It's because it's actually true. There are countless of people that I've turned around and I've helped recover from injuries, even myself. You've seen me recently deadlifting 315 pounds for the first time. Even though, and when I say for the first time, technically I did deadlift 365 pounds earlier, but I had happened to injure my elbows being a little bit more, what's the word I should be using? Having a little bit too much hubris and trying to fight extra hard, and I ended up injuring my elbow. So in that process, I had to do my rehab and build myself back to full strength to where I can actually support the weight that I'm holding on to pain-free. So what is an injury? And I'm going to share my screen with you so you can see exactly what it means. The fact of being injured, harm, or damage. Instance of being injured. Damage to a person's feelings. You like how I did that, right? If you know, you know. But when you injure yourself, or when you have been injured, there's a series of processes that have to happen in order for your body to make itself right. If you do not manage these particular things properly through the inflammation stages, through the healing stages, you are going to find yourself in a world of hurt. And as a matter of fact, if you injured yourself and do not take the proper precautions to actually do the work necessary to heal properly, the injury is going to be far less traumatic than the healing itself. I'm gonna repeat myself. For those of y'all who know that I go meta with this stuff, might not exactly be talking about the human body sometimes, but it still applies. If you have been injured, sometimes the healing process will be far worse than the injury itself. Case in point, you hurt your shoulder and you hold on to it, you baby it, you don't do anything with it, you just lay there and let it do what it does. And then after 6 to 8, maybe even 10 to 12 weeks, you decide that you want to start moving it now because it don't hurt no more. Well, bad news. You can't move it. It's locked to your body. And there's not very much that they're going to be able to do for you in that current state. There's not a lot they're going to be able to do for you to get that arm to move fully. So what that means is you have to actually go through some pain while in the process of healing. Shoot, this could be a psychology lesson too. But when you have been injured, you have to go through pain in order to heal. Some of y'all don't want to do that. Some of y'all are cowards. Some of y'all are feline. I'm gonna put it that way, so that way I don't get in trouble, because I know my mom watches. Some of y'all are feline. And y'all are too scared to feel the pain that is going to take for you to heal properly. And as a result, the healing is not going to work. Now, sometimes it just so happens to be that no matter how hard you worked, no matter what you did initially, some unforeseen circumstance either causes a re-injury or it doesn't allow you to heal properly. That doesn't mean you're feline then. It just means you got. It's something unfortunate happened. But for those of us who do not want to experience any kind of pain in the process of healing, you got to get over that. Because, and when I say pain, obviously, we don't want you feeling like somebody just hit you in the knee with a baseball bat if that's the part that you injured, or feel like you just took a knife to the shoulder. What we're saying is that there has to be some level of discomfort in your ability to heal while healing. And then finally, one day, your body is not going to even respond to the stimulus of pain because there's nothing to be afraid of. You are back to full strength. All right. So the next thing I want to actually touch on is the word rehabilitation. So if you have been injured, you have to be rehabilitated. You just can't go out there, I'm hurt, I've been hurt, I've done hurt. I've hurt people, I've hurt myself physically, and expect that everything is going to be fine because it's over. It's not over. You just got your hip dug into like I did. You're going to have your knee dug into like some people I know, or like some people have already experienced that I know. You're going to have your knee dug into. And guess what? It's not going to feel good when you wake up. God willing, you wake up. When you wake up, you're going to feel uncomfortable. It ain't going to feel pretty. But guess what you got to do? You got to put in that work. And it's not going to feel good. And in that rehabilitation process, you are going to have to grow. But you have to grow a specific way. So I'm going to move on to rehabilitation. Like I said, rehabilitation meaning is the action of restoring someone to health or normal life through training and therapy after either imprisonment, addiction, or illness. Last but not least, injury. They're missing a word. The action of restoring something that has been damaged to its former condition. Bad news. You will never be back to your former condition. You have lost 1 hit point, maybe even 5, every time you injure a body part. Every time you injure a body part, expect anywhere between 2 to 6% of your functionality to diminish. Now, even though it is 95% of what you used to be, doesn't mean that you can't get stronger, because what all that means is that 5% stronger that you've gotten is now, it's now less. It's the 5% that you're stronger. Could have been 10 had you been healthy, had you not been injured. But that doesn't mean you can't improve. It doesn't mean you can't grow. It doesn't mean that everything's going to feel like it used to feel before you got hurt or before things got bad. You're going to go through some stuff. And when we are dealing with rehabilitation, the one thing that people have to understand is that you have to be rehabilitated. You have to be worked on, go through pain, and you have to go through that pain for as long as it takes until you don't feel that pain anymore, and you can either step out into society as a person, or in terms of your ability to be physical, you have to be ready to step out there and deal with the harsh environments as it comes. But if you don't, all you're going to do is fall back into re-injury. Does that make sense? So, okay. So I'm going to read a few things to y'all, but I want to share this with you in a way where share it with my screen. So, this is from the NIH. Rehabilitation is a process in which physical, sensory, and mental functional capacities are restored or developed after damage. The context of injury control, rehabilitation is a process by which biologic, psychologic, and social functions are restored or developed to permit an injured person to receive maximal personal autonomy and an independent, non-institutional lifestyle. That is in everything. This is not just talking about jail. This is not just talking about slavery. This is all talking about even in physical and brain damage injuries. Traumatic brain injury to be specific. So that means rehabilitation is achieved not only through functional change in the person, i.e. development of compensatory muscular strength or use of prosthetic limbs and treatment of post-injury behavioral disturbances, but also through changes in physical and social environment, such as reductions in architectural and attitudinal barriers that hamper those requiring use of a wheelchair. So for those of y'all who don't know, have you ever seen some of these gangsters in wheelchairs, that they are even more physical than you can be in your full, your fully able body. And they're doing things so amazing that you like, man, he's doing push-ups in a wheelchair. Dang, she's doing pull-ups in a wheelchair. She plays basketball and she could actually cross me up in a wheelchair. Makes you kind of feel bad sometimes, like, man, what's wrong with me? But this is what rehabilitation is. The last decade, improvements in emergency medical systems, in immediate management by trauma centers, and in care of the injured en route to hospitals have increased the survival of persons with nervous system injuries, multiple injuries of the musculoskeletal system, and viscera, or extensive burns. My brain, I was trying to say vice versa for whatever reason. But anyway, trauma units have increased the need for defined referral to special rehabilitation programs and follow-up services. So for instance, you injured your leg in a horrific way, in a way where you don't even know, nobody wants to see that. You got to see it, but nobody wants to see that. The rehabilitation, the next steps that are taken can be the difference in back to full function, or you're in ambulatory aid for the rest of your life. For instance, you suffer a stroke. The faster you get to the hospital, the higher chances of your survival and the higher chances of your ability to not feel long-term physical effects from that stroke. The faster you get in, the better chances you have. Trauma units have increased the need for defined referrals to special rehabilitation programs and follow-up services. More persons survive major injuries and need functional restoration of cognition, sensation, and movement control and mobility after brain, spinal cord, and musculoskeletal injuries. Further negative effects on health and performance in daily life that results from the loss of body parts and from inactivity and immobility must be prevented. Remember what I said about sitting there holding your arm for 6 to 12 weeks and then all of a sudden expecting to be able to move it because it don't hurt no more? This is what I was talking about. When people have musculoskeletal injuries, whether it be through surgery or through the natural course of order, meaning that you hit something or something hit you or you landed awkwardly or you made a move and your body just didn't respond the way you planned to, there's a series of steps that you must go through in order to actually go through rehab properly. So what we're going to do is we're going to look at rehab of the ACL. Now, one of the things that So let's start with rehabilitation of a ligament. Actually, let's read this. Rehabilitation for a ligament injury typically involves combination of exercises, therapy, and other treatments to help regain strength, stability, and range of motion. Exercises, therapy, other treatments, crutches, ice, bracing, and internal bracing, right? So let's start with exercises. If you are dealing with anybody that's either a therapist or a corrective exercise specialist, these exercises will create a customized plan of exercise to help with healing and prevent future injuries. These may include stretching, strengthening, and coordination exercises. For example, to strengthen the thigh muscles in your affected leg, you might lie on your back and lift your leg while keeping your knee straight. Therapy, physical therapy is a key part of recovery. Please, for the love of God, if you ever get surgery, do not think that you're capable of just doing it on your own if you are not specialized in rehabilitation. And as a matter of fact, even if you are specialized in rehabilitation, you need to be an active participant in your rehabilitation plan, but you need to trust other people with your rehabilitation plan that will challenge and push you to your limits, so that way you will not only grow stronger, but you will avoid re-injuring or setting yourself up for an injury because you have not done the proper training to help your body recover and become more proprioceptive, which means understand where your body is in space when you're out in the regular world. Other treatments. You might also receive ultrasound, heat therapy to improve circulation, or deep massage to increase flexibility. Ice therapy, which is next. We'll get to that. Crutches. You might be given crutches to help you move around for a couple of weeks. Ice. You might be advised to apply an ice pack to the injured area several times a day to reduce swelling, because swelling is inflammation, and inflammation is only good for a certain period of time. After that, inflammation is horrid. Bracing. You might need to wear a brace full time during a certain phase of recovery because the ligament is unstable. You need something to maintain some level of stability as you recover. And internal bracing. In some cases, synthetic internal brace might be used to provide additional strength to the healing tissue, meaning they might put something on the inside of your leg, specifically since we're talking about ligaments in the leg. You might be able to do that. Okay, so the ACL, the anterior cruciate ligament, is a key structure in the knee joint kinematics as it resists anterior tibial translation. That means if this is your femur and this is your femur and this is your tibia, anterior translation means it's sliding forward. Posterior translation, it means it's sliding back. Or if you're looking at it from the femur end, your femur slides back if it's an anterior translation, or your femur slides forward in a posterior translation. Okay? It also prevents excessive tibial medial lateral rotation, meaning this right here. And as varus valgus stresses, which is this right here, bending your knee side to side. despite that of its primary role as a proprioceptive function due to the presence of mechanoreceptors in the ligaments. Because of an ACL injury might therefore be regarded as a neurophysiological dysfunction and not as a simple peripheral musculoskeletal injury. As a consequence of its complex role in the kinematics of the knee, when an ACL injury occurs, there are both clinical signs and subjective instability, and therefore a comprehensive rehabilitation program is needed. Injuries to the ACL are relatively common knee injuries among athletes and females who are 2 to 8 times more likely to sustain an ACL injury than their male counterparts. It's because of something we call the Q angle. Q angle is the hip width ratio to knee width ratio. If you have a bigger Q, the bigger your Q angle, the higher your probability of knee injuries, especially ACL knee injuries. And this is assuming that there's non-contact, because 70 to 75% of all knee injuries are usually non-contact. Injuries can range from mild, by the way, I haven't read this. I just pulled it up because it's relevant to what it is that I'm talking about. The injuries can range from mild, such as small tears, which is a sprain, to severe, which is when the ligament is completely torn. That is called a grade 3 tear. When an ACL has a complete rupture, there are clinical and subjective signs of instability. You literally can't walk on it. Well, you can walk on it. It won't. I've had people blow their ACL and still play on it. Didn't even know that they did it because they just felt a little unstable, but they mentally made adjustments and continued to play. However, those of you who are sensitive to such injuries, you will start noticing that when you make steps certain ways, your knee doesn't feel stable. You feel like you're almost buckling, right? Even though there's nothing to buckle against. The injuries can range, I already went through that. A surgical reconstruction is needed. However, it is not self-evident that an ACL reconstruction will automatically lead to a return to pre-injury activity levels. If you don't follow the plan, that's for sure. It won't happen. So as you can see right here, this is the ACL right here. This is your LCL. If you're looking at it since this is the tibia, this is your right knee that they're looking at. And since this is your right knee, your lateral collateral ligament is here, your medial collateral ligament is here, and behind here is your posterior collateral ligament or posterior cruciate ligament, and this is your ACL, which is your anterior cruciate ligament, which is what you're looking at here. It prevents, as you can see how it crosses over the tibia like right here. If you pushed from behind, you'll notice that it doesn't allow your knee to shift, your tibia to shift forward or translate your femur posterior. Okay? The ACL is a band of dense connective tissue which courses from the femur to the tibia. The ACL arises from the posterior medial corner of the medial aspect of the lateral femoral condyle. So what it's saying is that it runs from the back of the lateral head of the back portion of the lateral head of your femur. Since it's on the right side, if you look at where I'm rolling right here, let's see if I could actually get us over a little bit. There we go. So my bad. So this is your ACL right here. This is what I'm pointing at right here. What I'm running right here is your ACL. This is your LCL, which is your lateral collateral ligament, because this is the right knee. That's your patella, that's your kneecap, that's your femur, that's your thigh bone. This is your MCL, which is your medial collateral ligament. This is the one that keeps your knee from buckling inwards. This is the one that keeps your knee from buckling outwards. Excuse me. But as I read just recently, this is your ACL runs from the posterior part of your lateral head of your femur all the way to the medial condyle of your tibia. So let me read that again. The medial aspect of the lateral femoral condyle. So the inside portion, so if I'm reading this in layman's terms, the inside portion of the lateral femoral condyle, which is the big bone that sticks out off the lateral side in the intercondylar notch and inserted anterior to the intercondyloid eminence of the tibia, meaning this little gap right here. There's a gap in your tibia, and it's right in between there, blending with the anterior horn of the medial meniscus. The ACL courses anteriorly, medially, and distally across the joint as it passes from the femur to the tibia. As it does, it turns on itself in a slight outward lateral spiral. So meaning you turn lateral, it turns on itself. The density of blood vessels within the ligaments is not homogeneous. It's not a lot. In the ACL, an avascular zone is within the fibrocartilage of the anterior part where the ligament faces the anterior rim of the intercondylar fossa. The coincidence of poor vascularity and the presence of fibrocartilage is also seen in gliding tendons in areas that are subjected to compressive loads, plays a role in poor healing potential of the ACL. So this is part of the reason why blood needs to go. You need a lot of blood in that area. So this is why when you actually damage it and it swells up, this is why blood is rushing to that area to try to do something with it. But guess what? It can't do much with it because all it's going to do is lay down scar tissue and lock your knees up. You need reconstructive surgery, but in the process of that reconstructive surgery, you're going to need to allow it to swell some, to allow the ligament to be quote unquote strengthened, or the reconstructive ligament to be strengthened. Okay, general considerations. ACL rehabilitation has undergone considerable changes over the past decade. Intensive research into the biomechanics of the injured and the operated knee have led to movement away from the techniques of the early 1980s characterized by post-operative casting, delayed weight bearing, and limitation of range of motion to the current early rehabilitation program with immediate training of range of motion and weight bearing exercises. Meaning you are not going, if you blew your ACL, you are going to be weight bearing immediately, but you're not going to be full-blown activity level active. You're not going to be cutting and jumping, and like if you blew your ACL and you play football, you're not going back to full-blown activity until they clear you. You have to demonstrate that there's no pain, your proprioception is good, your ability to change direction without re-injury is there. You have to go through all of this in order to make that work, okay? So let's keep going. ACL rehabilitation is both conservative and surgical, is both for conservative and surgical options. Conservative treatment of an ACL injury could be the best choice for sedentary patients. I disagree. What I would say when they say conservative, that means you are exercising still, but you're not jumping, you're not stepping on things, you're not trying to shift your weight from one thing to another just yet. You're building to that at a very slow pace. Indeed, patient age, sportive activities, and foremost subjective instability symptoms in daily life activities should be considered when deciding for or against ACL reconstruction. Personally, I think you should just get it done, but in the time frame that you're doing it, you should be working towards growth. In those cases, a physiotherapeutic program of complete regain of range of motion, a comprehensive program of reinforce and restore proprioception, and a normal gait pattern training could be the best rehabilitation protocol. However, if symptomatic instability of the knee is not reduced after physiotherapy nor after adjustment of activity, anterior cruciate ligament reconstruction is recommended. Meaning, if you can't maintain any type of order and control of your knee and in unstable environments or stable environments at any time after you have gone through such physiotherapy, you need reconstructive surgery, then you need to go through rehab again. This might prevent multiple interventions because of the further meniscal and cartilage damage. Because the more unstable your knee is, you're rubbing and twisting and tearing your meniscus up if you don't do this right. It is useful to remember that injuries to the ACL rarely occur in isolation. The presence and extent of other injuries may affect the way in which the ACL injury is managed. Indeed, the mechanism of injury can damage also the medial collateral ligament, the MCL, or the meniscus. Other associated injuries could be microfractures of bone contusions, both with or without chondral injuries, meaning you might have blown any of your other ligaments in your knee. You might have torn the meniscus in the process as well as the ACL, or you might have done some microfractures to the condyles of both the femur and your tibia or your tibia. So here we go. The major goals of rehabilitation of the ACL: injured knee, gain full range of motion of the knee, repair muscle strength and proprioception, gain in good functional stability, reach the best possible functional level walking, running, and jumping, decrease the risk for re-injury, and return to sport. So these are your stages: the acute stage, pre-surgical stage or conservative treatment, post-surgical stage, and return to sport. Acute stage: after ACL injury, regardless of whether surgery will take place or not, physiotherapy management focuses on regaining range of motion, strength, proprioception, and stability. In the acute stage, peace and love should be used in order to reduce swelling. Peace and love is an acronym, I'm sure. So let's click on it, right? Open link in new tab. Peace and love. Peace, protect. E, elevate. A, avoid anti-inflammatory modalities. Anti-inflammatory medications may negatively affect long-term tissue healing, which means do not take NSAIDs, do not take Tylenol, do not take Aleve, do not take ibuprofen at this time, because you need all the blood and inflammation in that knee as much as possible at first, okay? Avoid ice. I don't know about that one, but actually, yes, avoid ice for the moment. Use of ice is mostly analgesic. Not true at all, actually. That's not true. Analgesic means that's only at the surface. Not true at all. It actually affects at deeper tissue levels if you leave it on long enough without damaging the tissue. Although it's widely accepted as an intervention where there is very little high quality evidence that supports the use of ice in the treatment of soft tissue injuries. That is BS. Okay, 100% BS. I'm gonna stop reading this. Ice may potentially disrupt inflammation, angiogenesis, and revascularization. That is true. Ice may potentially delay the neutrophil and macrophage infiltration, which is why I just said don't do it at first. So amazingly enough, if it's so make this make sense. As a matter of fact, let's keep it real. If it is affecting the neutrophils, the macrophages infiltration, which is the things that both put healing matrix, protein matrices inside the injured area, and the macrophages, which eats all the dead tissue and destroys all the dead tissue and tries to keep out inflammation or tries to mitigate inflammation. Why does ice work against it? Because it does, in fact. And why do they not want you to take anti-inflammatory medication? Because they want it to swell so that way the ligament can have some sort of healing done to it, or even on a microscopic level. Okay? Ice may potentially increase immature myofibers, meaning more muscle tissue. Myo is the prefix for muscle. This can result in impaired tissue regeneration and redundant collagen synthesis. This is part of the reason why, but this is what we're saying. We're saying it's not that you don't want to use ice personally. It's what you want to do is you want to use ice in a way where it is manipulating the structure. So you basically, it's kind of like, let's say you're building a wall, no pun intended, but you have to use concrete, you have to use cement. And when you use that cement, if you use too much, if you don't shave off that excess cement, it's going to look ugly and it's going to be pointless, right? Whereas if you shave off too much, then the wall is not functional, right? It's the same difference with any body part that is injured. If you shave off too much, or if you don't allow enough material to be put on, the healing process will not be as effective. Compress and educate, meaning exercise, and educate yourself on the injury itself. I'm not going to go through everything. Love is load. Patients with musculoskeletal disorders benefit from an active approach with movement and exercises. Optimism, vascularization, and exercise. So peace and love. There you go. So now that we know what peace and love is, the indication of use of crutches and eventually a knee immobilizer could be appropriate in some patients. However, extended use of the knee immobilizer should be limited to avoid quadriceps atrophy. Your quadriceps are going to be a major part of your stabilizers. Actually, all of your leg is going to be a part of that. Glutes, hamstrings, quads, TFL, gracilis, sartorius, right? And when I say glutes, that's medius, minimus, and maximus. The neuromuscular inhibition of the quadriceps caused by intra-articular effusion may have a negative effect on strengthening. In any case, exercises should encourage range of movement, initial strengthening of the quadriceps and hamstrings, and eventually proprioception. In fact, strength and proprioceptive alterations occur in both the injured and uninjured limb. To assist preoperative optimization, the following guidelines are recommended in the acute and early subacute stages of post-injury. Full extension is obtained by doing passive knee extensions, patellar self-immobilizations, which is you are taking your kneecap and you're just wiggling it around. That's you doing that, not your therapist. You physically locking your leg out, not locking your leg out, but extending your knee a little bit in a relaxed state, and then allowing it to be moved. Heel props, meaning you put your heel on top of something. Prone hang exercise. That I don't know what is. I don't know what that is. I've never done that before. Static quads, meaning you hold it. Bending. Flexion is obtained by doing passive knee bends. Knee flexion in prone when you're laying on your stomach. Oh, prone hang exercise. I know what it is now. So you're basically laying down and your leg is laying straight. You're hanging your legs over something to allow your knee to go straight. And wall slides. Ooh, wall slides. Heel slides. Ooh, my God. Oh. Knee flexion, extension in sitting. Ankle dorsiflexion and plantar flexion and circumduction, meaning you're moving your ankle in every direction possible. Glute medius work in side lying, meaning the leg that's injured, you're laying down and doing glute medius work. Gluteal exercises in the prone, so you're doing glute exercises laying on your stomach. Weight transfers in standing, meaning you're stepping forward, stepping backwards, and then you're stepping side to side. And as you do that, you'll get used to everything, and that's how you get through all of that. So I'm just going to skip some of this. what you do during, as soon as the acute stage is over, it is important to prepare the knee for surgery as well as possible to optimize the outcome. The focus needs to be on strength and proprioception. Despite this, the physiotherapist must keep the injured knee in a quiescent state, improving the range of motion with minimal swelling. Let's Google quiescent. A quiescent. Quiescent. Look it up. Quiescent, in a state or period of inactivity or dormancy. Quiescent. Ricin electrotherapy can be applied during several weeks ahead of the surgery in order to obtain full range of motion to increase joint effusion, meaning locking up. If I'm right, if I remember my terminologies correctly. An instance of giving off something such as liquid, light, or smell. That's true too. Okay. The patient should also have a normal gait pattern. Because of that, it is useful to analyze the motion of the leg both in the swing phase of walking and in the one leg standing phase. Thus, will help the patient to regain faster motion and strength after surgery. Maintain full range of motion in an extension and keep improving range of motion in flexion with minimal swelling. Develop muscle strength. Swimming, low impact, leg press machine, leg curl, leg extensions, and weight bearing exercises such as squats, lunges, and step ups. Closed kinetic chain exercises. That's what that is. Improve proprioception. One leg standing exercises, adding balance cushions, one leg standing exercises in different planes, frontal, sagittal, and preparation for controlled jumps. That's preparation. That's the later stages. 4, keep the compliance to rehabilitation program high, meaning you must be in rehab. You cannot avoid it. Do not avoid it. Do not, circumvent it. You must get through it. After surgery, consider pain, swelling, muscular contracture, limitation in range of motion, abnormal gait patterns such as indicators for having a good outcome. In the after surgery stage, 3 factors are important. Early terminal knee extension equal to contralateral side, meaning the side that's not injured. Early weight bearing, closed and open kinetic chain strengthening exercises. Peace and love is week 1. We're not going to go through all of this. Week 1. Full extension and 70 degrees of flexion by the end of the first week. That's how aggressive this is. So you're not even at 90 yet, but you're at 70% by the first week. Use a knee brace and crutches in agreement with the surgeon and only if needed. In fact, the wearing of the knee brace has no additional treatment value after ACL reconstruction. It's only for it's the feather in your nose, Dumbo. The use of the knee brace is progressively reduced by authors, meaning the people who write your scripts. Post-operative rehabilitation bracing, either in extension or with the hinges opened for range of motion, does not offer significant advantages over no bracing. We're going to skip over this. Multi-directional mobilizations of the patella should be included for at least 8 weeks. Other mobilization exercises in the first 4 weeks are passive extension of the knee, no hyperextension, and passive and acute and active mobilization towards flexion, meaning both forced and you actually performing the task. Strengthening exercises for the calf muscle, because when the foot is fixed to the floor, the calf extends the knee. I'm going to repeat myself. When the foot is fixed to the floor, your calf extends your knee. Hamstring and quadriceps vastus medialis can be performed supine or prone, back or on your stomach. Isometric quadricep exercises are safe from the first post-operative week, meaning holding quad exercises. Early weight bearing appears beneficial and may decrease patellofemoral pain. 3 through 4, there's no evidence that icing and elevation is useful after week 1. I disagree. The first goal is to maintain full extension and increase degrees of flexion week by week. Try to genuinely increase the stance phase in attempt to walk with one crutch. With good hamstring quadriceps control, the use of crutches can be reduced earlier. I'm going to skip some of this. Week 5, passive mobilization should normalize motility, but flexion should not yet be thorough. Tonification of hamstrings and quadriceps can start with more intensity both in open and closed chain exercises. The exercises should start on light intensity, 50% of maximum force, and now progressively increase to 60 to 70. The closed chain exercise should be built from less responsible positions, leg presses, or steps, to more congested starting positions. Example, the squat. They meant squat. The progress of exercise depends on pain, swelling, and quadriceps control. That's 5 to 9 weeks. Progression of loading is the fundamental from now on. Proprioception and coordination exercises should be more specific to the individual sporting needs of the patient. If the patient does not wish to return to the sport, these exercises fulfill his ADL needs, active daily living needs, climbing stairs, walking uphill, downhill, skating, swimming. Even if they're not returning to sport, they still might want to actually participate in activity some ways. Forward, backwards, and lateral dynamic movements can be included, as well as isokinetic exercise. And the reason why that's important, the reason why I strongly suggest that you actually participate in active movements, is when you find yourself in an unstable environment, such as an uneven surface or a slippery surface. You don't want to re-injure yourself because you don't have the skills necessary to control your body when you have no control over your body. 3 months, which is 90 days, which is 3 months, which is 12 weeks. Yeah. After 3 months, the patient can move on to functional exercises such as running and jumping. As proprioceptive and coordination exercises become more intense, faster changes in direction are possible. To stimulate coordination and control through efferent and efferent information, which is your spinal cord and your brain, exercise should be enhanced by variation in visible input, surface stability or trampoline, speed of exercise performance, complexity of the task, resistance, 1 or 2-legged performance. Month 4 or 5, the final goal is to maximize endurance and strength of the knee stabilizers, optimize neuromuscular control with plyometrics, and add sport-specific exercises. Acceleration and deceleration variations in running, turning, and cutting maneuvers improve the orthokinetic reflexes to prevent new trauma during competition. So that means after 6 months, you should be almost ready to go. However, it is safe for people to go 8 to 12 months to ensure that their performance levels have reached peak ability prior to the injury at hand. And that is where I will land the plane. It is 8 o'clock Mountain Standard Time, and I've got some things to do. So, if you learned anything or if you have any questions, feel free to hit me up in the comments. Don't forget to like, subscribe, share, follow me on Facebook, Instagram, and on YouTube. Have a nice day. Be the best you. Class is Stoutt.